Hello, my name is Bailey. Today we're going to be looking at an interactive case study that is focused on misdiagnosing mental health disorders. This client was initially seen in office in September of 2024. Her chief complaint was anxiety symptoms like intrusive thoughts, inability to focus, and panic attacks, depressive symptoms like low energy level, insomnia, and napping daily, being overly emotional. She was concerned that the symptoms she was having was related to undiagnosed ADHD, which was the reason initially for her scheduling an appointment. Now we're going to go over the details of the client's history. The HPI, or history of present illness. The client is a 36-year-old Caucasian female from Colorado. She has been on Prozac for 1.5 years, has tried Zoloft and hydroxyzine in the past with no relief of symptoms. She's currently trying to establish care with a therapist, currently experiencing significant weight loss of 105 pounds. Although she is prescribed the medication semaglutide, she eats small portion meals 3 times a day. She was placed on FMLA at a recent job after her boss believed she was emotionally unstable. She hired an attorney and agreed to leave the job with a settlement of 6 months worth of pay. Says that she was not able to sit in on any one-on-one meetings as this caused increased anxiety and panic attacks. She complains of being distracted easily and not able to complete tasks while working. States she is hyper-aware in public and startles easily. Denies manic episode, denies hallucinations and delusions, says people thought she was quote-unquote crazy as a child, but could have been seizures as she does have a diagnosed seizure disorder. Describes public seizures as traumatic, complains of sudden irritability that is unpredictable, complains of interrupted sleep, waking frequently with a total of 5 to 6 hours of sleep every night for the past several months. Depression started in high school. Currently, depressive episode has been for 2 weeks. Complains of low energy levels, insomnia, must force herself to get out of bed, and naps daily. She has been diagnosed with anxiety and depression in the past, but is concerned that she may have undiagnosed ADHD that may be the culprit for her current symptoms. Diving into interactive question number 1. After reviewing the client's chief concern and HPI, which screening tool is least beneficial in determining the severity of current symptoms? A. PHQ-9, B. GAD-7, C. MDQ, or D. EDE? Please pause the video and give yourself some time to answer the question before resuming to find the answer. The correct answer is D. EDE. This screening tool is least beneficial in determining the severity of the client's current symptoms. Rationale behind this question. A's answer choice was PHQ-9, which is a self-assessment tool used to determine the severity of depressive symptoms. This tool is appropriate for this client who complains of fatigue, insomnia, and is taking naps daily. B's answer choice was the GAD-7, which is another self-assessment tool used to determine the severity of symptoms related to anxiety. This client has complained of intrusive thoughts, panic attacks, and the inability to focus, so this assessment tool is essential to her plan of care. C's answer choice was the MDQ, which is a mood disorder questionnaire. It does screen for bipolar disorders and is necessary for this client due to her complaints of being labeled as emotionally unstable. D's answer choice was the EDE, which is an eating disorder examination. This assessment tool is not necessary for this client. She does state that she is eating 3 meals a day. She has lost a significant amount of weight. However, she is also taking a medication that promotes weight loss. Her medical history consists of migraines, epilepsy, poor balance, celiac disease, insomnia, childbirth ×1 via cesarean section in the year of 2020, cholecystectomy in the year of 2020, appendectomy in the year of 2024. She has also had a tonsillectomy. The year is unknown. Her family history is pretty insignificant. She does have an uncle that has a history of substance use disorder. Unsure if this is a maternal or paternal uncle. She denies any other mental health family history. Social history. She lives with her husband and daughter. Her highest level of education is a master's degree. Her work history includes school administration and executive assistant to the Commissioner of Education of Colorado. She is currently unemployed. She denies drug dependence. She's a former smoker. She consumes 6 alcoholic drinks weekly and started drinking at the age of 16. She does have a Catholic background but no longer practices, and her parents are still married. She does have a positive relationship with her mother and younger brother. Psychiatric history. She does state that she experienced social bullying in middle school. She described this as peers trying to change how she looked to help her be popular. She then described bullying in high school and college. The college bullying was more severe as her 2 friends cut her off socially, and she described how difficult it felt for her to live a normal life on campus. She described transferring colleges and thriving at her new college, making new friends, and meeting her husband. She denies a history of physical, emotional, or sexual abuse. However, she does report a trauma history due to her epilepsy. She began experiencing epilepsy in high school, having seizures in public and in the middle of a city, which was traumatic for her. She says her family has always been very supportive and ensured she was receiving care for her epilepsy, but fell short on mental health support, as she did not start seeing a therapist until the age of 30. She has history of uncontrollable thoughts, difficulty taking care of her child and maintaining a job. She has emotional outbursts, history of panic attacks, no history of suicidal ideation or suicide attempts. However, she does have history of self-harm behavior, such as rubbing her skin until she has burn marks or picking at her head until there are wounds present. Interprofessional collaboration. After this patient was initially seen, the provider decided to refer her out for a full psychological examination to determine if her symptoms were truly related to ADHD diagnosis. This exam was done in November of 2024 and was done by a licensed psychologist. The lists of testing is on the right of this slide. Before we're talking about diagnoses, we're going to move on to interactive question number 2. After reviewing her history, which diagnosis would least likely be included in the differentials for this client? A. Bipolar disorder. B. Schizoaffective disorder. C. Panic disorder. Or D. Major depressive disorder. Please pause the video and give yourself a few minutes to answer the question before resuming to find out the answer. The correct answer is B. Schizoaffective disorder. This diagnosis is least likely to be included in the differentials for this client. The rationale behind this question: answer choice A's was bipolar disorder. The client denies symptoms of mania. However, she does complain of intrusive thoughts and disturbed mood. She has history of being labeled as emotionally unstable and crazy. It would be worth monitoring this client for further manic symptoms. Answer choice B was schizoaffective disorder, which was the correct answer. The client denies any hallucinations or delusions, which fit the criteria for schizoaffective disorder according to the DSM-5. Therefore, this is not an appropriate diagnosis to work up for this client. Answer choice C was panic disorder. The client does complain of anxiety-related symptoms and panic attacks. It is important to get more history related to this, as diagnosis could be a potential pending specific panic attack symptoms, frequency, and what long-term symptoms follow panic attacks. Answer choice D was major depressive disorder. This client does complain of depressed mood, weight loss, insomnia, fatigue, and inability to concentrate. All of these symptoms are included in the criteria for major depressive disorder in the DSM-5. Therefore, this would be an appropriate differential diagnosis for this client. Now we are going to review diagnoses. This is a list of differential diagnoses based on the client's symptoms: major depressive disorder, bipolar II disorder, attention deficit hyperactivity disorder, adjustment disorder with depressed mood, generalized anxiety, anxiety due to another medical condition, social anxiety disorder, panic disorder, mild neurocognitive disorder, specific learning disorder, insomnia disorder, restless leg syndrome, or breathing-related sleep disorders. The client is currently diagnosed with major depressive disorder, generalized anxiety, mild neurocognitive disorder, and insomnia disorder. For major depressive disorder, the client meets the following DSM-5 criteria: 5 or more symptoms of depressed mood most of the day, nearly every day, as evidenced by subjective report, significant weight loss, insomnia nearly every day, fatigue or loss of energy nearly every day, diminished ability to think or concentrate or indecisiveness nearly every day. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The episode is not attributable to the psychological effects of a substance or another medical condition. At least one major depressive episode is not better explained by schizoaffective disorder and is not superimposed by schizophrenia, schizoform, delusional disorder, or other specified or unspecified schizophrenia spectrum and other psychotic disorders. There has never been a manic or hypomanic episode. For generalized anxiety disorder, the client meets the following DSM-5 criteria: excessive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities. The individual finds it difficult to control the worry. The anxiety and worry are associated with 3 or more symptoms: restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or going blank, irritability, and sleep disturbance. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The disturbance is not attributable to the psychological effects of a substance or another medical condition. The disturbance is not better explained by another mental disorder. For mild neurocognitive disorder, the client meets the following DSM-5 criteria: evidence of modest cognitive decline from a previous level or performance in one or more cognitive domains, documented by a standardized neuropsychological test. Cognitive deficits do not interfere with capacity for independence in everyday activities. Cognitive deficits do not occur exclusively in the context of delirium, and cognitive deficits are not better explained by another mental disorder. For insomnia, the client meets the following DSM-5 criteria: a predominant complaint of dissatisfaction with sleep quantity or quality associated with difficulty maintaining sleep characterized by frequent awakenings or problems returning to sleep after awakenings. The sleep disturbance causes clinically significant distress or impairment in school, occupational, educational, academic, behavioral, or other important areas of functioning. The sleep difficulty occurs at least 3 nights a week. The sleep difficulty is present for 3 months. Sleep difficulty occurs despite adequate opportunity for sleep. The insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder. Insomnia is not attributed to the physiological effects of a substance. Coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. Relevant input from other providers. When she had the full psychological examination, the summary included that she was agitated when taking certain tests, that her behavior during testing may support a dysfunction with attentiveness and impulsivity. She presented positive findings with ADHD. She did perform at an average rate on the WAIS-4 with lower scores on processing speed and perceptual reasoning, indicating issues with controlling attention and processing visual stimuli, which are indicators of ADHD. The results on the MMPI and the MCMI indicate extremely strong results of cognitive dysfunction in complex attention, executive function, learning, memory, and perceptual motor skills, which is an indicator of a neurocognitive disorder rather than ADHD. Let's review evidence-based treatment options. Interactive question number 3. After reviewing her diagnoses, which medication would you choose to treat this client's insomnia? A. Zolpidem or Ambien. B. Lorazepam or Ativan. C. Trazodone. Or D. Methylphenidate or Concerta. Please pause the video and take a moment to review the question before resuming to find out the answer. The correct answer is C. Trazodone. Rationale. Answer choice A was Ambien. While this medication is often used to aid with symptoms of insomnia, this client is also diagnosed with a neurocognitive disorder. The side effects associated with Ambien include cognitive impairment. Answer choice B was lorazepam or Ativan. Benzodiazepines can be used for sleep. However, this medication also has negative side effects like cognitive impairment. Answer choice C was trazodone, which is the correct answer. And while trazodone is an antidepressant commonly used off-label for sleep, it is generally well tolerated. Since she also has a diagnosis of depression, this would be a good medication choice for this client. Answer choice D was methylphenidate or Concerta. This is not a good choice as this medication is a stimulant and is not indicated for sleep. Pharmacological interventions. This client is currently on antidepressant therapy. She does have a history of Zoloft with no benefit. She is currently prescribed Prozac 30 milligrams once per day. She is also prescribed trazodone, which is an antidepressant, but as we just discussed, this is used for in her insomnia. She does take trazodone 50 milligrams every night for sleep. She is prescribed a benzodiazepine and was on this prior to establishing care with the current provider. She's on Ativan 0.5 milligrams as needed. She gets 8 tablets every 30 days, and this is a weaning dose. She was previously prescribed 1 milligram. Because of the recent diagnosis of the neurocognitive disorder, this medication will be weaned and discontinued. For mood stabilization, she is on an antipsychotic, Vraylar 3 milligrams every day. She is also prescribed a sedative hypnotic, Ambien 5 milligrams every night. This medication has since been discontinued. She was on this when establishing care with the current provider, but again, because of her neurocognitive disorder diagnosis, this medication has been discontinued and the trazodone replaced this med. Non-pharmacological interventions. The client is currently participating in therapy. It was noted in her history that she had established care with a therapist at the age of 30. She is now 36. She did have a gap of treatment via therapy. However, she is now seeing therapy once a week and participating in cognitive behavioral therapy. The psychological evaluation, she did have the full psychological exam, and that was completed. Once she was diagnosed with a neurocognitive disorder, she then had a referral to neurology for further neurocognitive testing and treatment. Moving on to prevention strategies. Primary prevention strategies. The ultimate goal for primary prevention is to prevent the onset of any mental health diagnoses. We do this by promoting well-being and promoting positive mental health. It's important to consider reaching clients who have physical health diagnoses due to the link between physical and mental health. In your primary care settings and things like that, clients need to be educated on positive mental health and positive well-being so that mental health issues do not arise. Secondary prevention strategies. This includes early detection and treatment of diagnosable diseases. Secondary prevention includes things like screenings, education on local suicide hotlines and crisis centers, establishing diagnoses, and initiating non-pharmacological psychological and/or pharmacological treatment. Tertiary prevention strategies include interventions that reduce disability and enhance rehabilitation and prevent relapse. We do this by encouraging outpatient support, things such as therapy and group therapies, and stability with pharmacologic treatment. Community resources and mental health promotion. As a provider, it's important to know what is available in your community so that you can educate your patients on things such as crisis support, protected housing, and sheltered employment. In summary, in this case study, the provider made the right decision to do further testing rather than initially treating the client's ADHD symptoms. If a full psychological examination would not have been done, the client would not have been diagnosed with a neurocognitive disorder. The client would have had delayed treatment. It is important to note that the client's history of epilepsy and that she reported having traumatic brain injuries because of seizures in high school. Incorporating a thorough medical history should always be done prior to making a psychiatric diagnosis, as there are a multitude of symptoms that overlap for various disease processes. A misdiagnosis of ADHD and missing an important medical diagnosis such as a seizure disorder, diabetes in children, or thyroid dysfunction may have life-threatening consequences and long-term implications on the quality of life of patients. Here are the list of resources I used to create this case study. Thank you very much for following along and participating in the case study of misdiagnosing mental health disorders.